Dr. Worman, are you there?
Yes, I'm here.
Oh, okay. Dr. Moriyama will connect in 30 minutes. Sorry.
Okay, okay. We will waiting for his connection.
No, no. Please start.
Okay,
Yeah.
okay. I will start in 2 minutes.
Okay. Thank you very much.
Okay, okay. Thank you.
Yeah. Hello, Roman. Can you hear me?
What Sensei? Hello.
Yes.
Hello.
Nice to see you.
Nice to see you. Thank you for connection. Thank you
Okay,
very much
okay.
for your time. Thank you.
My pleasure.
Professor Ueda, hello. Nice to see you.
Hello.
We are waiting for Gianluca. Gianluca Esposito from Italy. I just sent him a message. Just a minute, please. Okay, dear colleagues, it's time to start. Thank you so much for connection, and would like to express my appreciation to organizing committee of APAN. And now we have very interesting 1.5 hour online course on the topic of intestinal metaplasia. And many thanks to our experts, Noria Ueda and Gianluca Esposito. As you know, those experts are the distinguished experts in the topic of chronic gastritis and intestinal metaplasia worldwide. So we have a really unique opportunity to ask some questions and to have some answers on our complicated and challenging questions. And I would like to highlight that today's format, it will be like discussion club. We have some presentation slides, we have some theoretical information and practical clinical cases, but we have a lot of questions. And as according to our experience, we have a lack of time every time to ask the question. And now we have the time for discuss our interesting and hot topic of intestinal metaplasia in stomach. So I think we should start the session. Sergey, could you say?
Thank you very much, Professor Ueda, Gianluca. It's a great pleasure for us to see you together with us. And thank you very much for your fruitful discussion.
Thank you so much. So let's start with the presentation. Okay, today we are going to discuss endoscopic findings and endoscopic diagnosis of intestinal metaplasia using basic standard like white light imaging with novel endoscopic techniques, image-enhanced endoscopy, magnifying and endocytoscopic features. Of course, we will discuss pitfalls and challenges in endoscopic diagnosis of intestinal metaplasia and present some challenging cases of gastric intestinal metaplasia. So, but the first question that we ask every time before we start endoscopic inspection and observation is the preparation of the mucosa, of the stomach mucosa. So, of course, we frequently have such pictures at the start of our investigation, a lot of bubbles, a lot of sticky mucus on the surface of the background mucosa, and we are unable to inspect the stomach and, of course, to make an appropriate diagnosis. Of course, we are unable to use additional techniques like image-enhanced endoscopy and magnifying endoscopy. We need to clean the stomach. This is the photo of preparation room from the endoscopic department of Professor Yao in Fukuoka University Chikush Hospital. Professor Yao has a special room just for preparation for upper GI, not for lower GI. He has additional room for lower GI, but for upper GI, he has additional preparation room. So patients usually use pre-medication with simeticone, with deforming agents, with pronouns and water before the procedure. And the gold Japanese standard is to use deforming agents and mucolytics like pronouns. But when European experts tried to investigate the necessity of mucolytics in the randomized, double-blind randomized trial induced by Portugal group, there was no additional effect of acetylcysteine when we use simeticone, water, and acetylcysteine. So there were no additional benefits. So the minimal recommendation for preparation, according to a European perspective and European data, is simeticone and water without acetylcysteine. But the using of mucolytics is very important, especially in patients with sticky mucus at the background of mucosa. And this is the first question for discussion. What is recommended to use in the clinical practice? Simeticone, acetylcysteine, Pronas, sodium bicarbonate, or other tips maybe for careful and quality cleaning the surface. Ueda-sensei, could you comment what is the best solution for preparation before endoscopic inspection?
It's a bit difficult question, but I think if we use some mucolytic agent like N-acetylcysteine and Pronase, I think it's better to really soften and remove the mucus on the surface of mucosa, especially the patient with active H. pylori infection. Sometimes the mucosa is covered with mucus. So in such situation, I think N-acetylcysteine or Pronase works better than simeticone. But many studies, probably it includes various type of patients. Most of the large-scale study or even meta-analysis show that the only simeticone shows the better mucosal visibility. So maybe in general practice, and also the cost issue also available for the N-acetylcysteine Pronase. So I think in general practice, I think simeticone and enough volume of water is enough. And if you really want to remove the mucus in a patient with active H. pylori infection, or if you want to apply, chromoendoscopy, especially methylene blue really stain the mucus on the surface. So in such situation, if you really want to perform more advanced endoscopy, I think mucolytic agent, combination of mucolytic agent as simeticone is better. This is my understanding.
Thank you so much. And what about sodium bicarbonate?
Sodium bicarbonate is only necessary for use of Pronase because Pronase activated in a neutral or alkaline situation, but N-acetylcysteine doesn't affect the pH by the pH. So Pronase should be used with a combination of sodium bicarbonate, but N-acetylcysteine can be used only N-acetylcysteine.
Thank you. Thank you for your comments. Gianluca, hello. Very nice to see you. Thank you very much for your communicate to us, for your connection. What is your practice? What do you usually do for your patient? Maybe outside of guidelines and evidence-based medicine, what is your personal recommendation?
Hi, Roman. Hi, Sergey. Thank you so much for the invitation. It's a pleasure to be here. So I completely agree with Sensei Ueda. I think that we should recommend the use of simeticone and acetylcysteine. We don't have, unfortunately, in Europe, we don't have Pronase, so we don't use Pronase and sodium bicarbonate, and that's our limit because it's not easy to build our preparation, our pre-medication for patients with simeticone and acetylcysteine. And that's why I think in real clinical practice, most of the endoscopists, when they perform an upper GI endoscopy, they don't use pre-medication. I think it's very easy to to do it, so to use Simeticon, because it's something very easy and you don't need to do such a work. You just, for example, in the recovery room, when the patient is approaching the upper GI endoscopy, so when he enters in the recovery room, that it's about 20-30 minutes before endoscopy, we give to the patient some water with Simeticon and N-acetylcysteine. But as Sensei Uedo already said, I think that most of the patients would easily be preparated only with Simeticon. Of course, when we perform something advanced, for example, using electronic endoscopy, or when we have patients, for example, with atrophic gastritis, sometimes with autoimmune gastritis, we see a lot of mucus in the fundus. So it's very important to have N-acetylcysteine in the pre-medication. I have to say that now most of the instruments, the gastroscopy, you can wash, and that's a big foot forward, because only if you have mucus that is very stick to the gastric wall, sometimes using the washing pump, you cannot see the mucosa. But most of the times, if you have only bubbles, just washing with your pump, you can clean the mucosa. But why arriving that? Because it's very easy to use Simeticon and it's very clearly clean the mucosa. So my recommendation is to use at least Simeticon 20-30 minutes before endoscopy. If you use N-acetylcysteine, it's even better, because you avoid to repeat gastroscopy in those patients who have a lot of mucus, and then you cannot see the underlying mucosa. And if you use virtual endoscopy or dichrome endoscopy, you cannot see very well what you are looking for. So I will recommend to use at least Simeticon, but if it's possible, to use Simeticon and N-acetylcysteine.
Thank you very much, dear colleagues. I have a question to both of you. What do you think about sodium bicarbonate? Because sometimes we use it especially in cases of autoimmune gastritis, and we find it very effective for washing and cleaning the surface of the epithelium.
But I understood that it is only necessary for pronase, but I don't have experience of only use of only sodium bicarbonate for preparation, so I don't know.
Thank you.
And can I comment one practical thing? So I think also the volume of water is very important for preparation. And before we used only 60 milliliter, but recently Kenshi went to Myanmar or Bhutan, which is still a very developing practice country. So they use 200 milliliter of water. So only Simeticon, but large amount of water really soften the mucus or remove the bubble, and very useful. And also sometimes really practitioner prohibit the patient to any drink or any food after dinner, but they allow the only transparent liquid is allowed to drink until 1 hour before the procedure, so that the mucus becomes very softened and very easy to remove with washing. So I think enough amount of water or to avoid very thirsty condition is very practical and important, useful preparation, I think.
Thank you for your
Yes,
comment.
I completely agree. Just one, sorry, Roman. Just one thing. The problem that we could have is with anesthesiologist. So if we give to the patient 200 milliliters before endoscopy, sometimes if you are doing with propofol, so under deep sedation, the anesthesiologist could say, okay, don't drink before the endoscopy. That's why when we suggest to use premedication, we usually suggest to take 20-50 milliliters of water. That is something that does not impair with the anesthesiologist. That's why a little amount of water before a deep sedation, it's better to, but I completely agree.
Okay, thank you. Thank you for your comments, Uedo-sensei, Gianluca, thank you so much. And just a small comment about sodium bicarbonate with the Simeticon. We have the Pronase. As you know, Pronase is not available in our country, and we tried to use sodium bicarbonate as a mucolytic also, because sodium bicarbonate has some mucolytic effect. But maybe we, according to our personal experience, we feel some benefits with cleansing effect on the sticky mucus in patients with autoimmune gastritis. So, but we should test this solution maybe in a small clinical trial to highlight the effectiveness. So thank you so much. Let's go further. And of course, this is our first chapter of today's conference, the endoscopic features of gastric intestinal metaplasia in basic modality in white light imaging. According to Kyoto classification of gastritis, as I understood, this is a 1.0 version, the first version of Kyoto classification available in English. We have one very specific endoscopic findings, so-called intestinal metaplasia. So, according to Japanese perspective, there are some specific features of intestinal metaplasia, and endoscopic intestinal metaplasia or specific intestinal metaplasia defined as the grayish white mucosa or ash-colored nodular change in the gastric antrum or corpus, and this is it is defined as endoscopic intestinal metaplasia. Ueda-sensei, am I right? Is
yes.
it right?
Yes. So I think this is the first report of endoscopic appearance of intestinal metaplasia. Previously, intestinal metaplasia is just understood as I think still understood that as terminology for histology. But I think 1960s, Dr. Takemoto published this as this type of appearance is the representative finding of intestinal metaplasia.
Thank you. So traditionally, endoscopic intestinal metaplasia is the grayish white mucosa.
Yes.
And the features highlighted in the Kyoto classification, intestinal metaplasia, it is only for whitish patch of mucosa of antrum or corpus. Am I right? Just whitish mucosa. Okay, and in the Kyoto classification, we also have some findings that could be associated with the intestinal metaplasia. So it is very specific findings like map-like redness that usually identified in patients after successful eradication therapy for Helicobacter pylori. And also patchy redness also could be associated with the development of a gastric intestinal metaplasia. So patchy redness and map-like redness, is it the same phenomenon but different size? Ueda-sensei, what is what is it is at the left and right side, it is areas of intestinal metaplasia, but it is the different endoscopic features. Is it the same or it is different features?
Very difficult question. Both finding have same characteristic, reddish color and then depressed from the surrounding mucosa. But the difference is probably the left side is more, independent patches. But the right side is almost like a little bit merged, unified, depressed area. So according to my experience, usually gastric intestinal metaplasia in the antrum is really isolated patches. But sometimes intestinal metaplasia, often intestinal metaplasia corpus is like a large area is unified and cause like a large area, like a geographical map or something. So I think the characteristic appearance, color and the appearance, shape, morphology is the same, depressed, but just the shape or distribution is different. I think that represents some, regional, yeah, localization, no, corpus or antrum. Actually, we have investigated the difference in appearance, morphology or something in intestinal metaplasia in the antrum and corpus, but those are little bit different. So I think it just represented the different region.
Okay, thank you for your comment. And once again, intestinal metaplasia in antrum is like patchy redness, and in corpus, much more likely to be map-like redness.
Yes.
Okay,
Mm.
okay. And as I understood the Kyoto classification, the patchy redness could be could be the gastropathy or gastritis. And because it could be detected in Helicobacter pylori infected patients, in uninfected patients, and after eradication also. And map-like redness with specific margins is quite specific for intestinal metaplasia. But how to differentiate, how to diagnose intestinal metaplasia in patchy redness? Maybe the margins is the key. Maybe the depressed morphology is the key for diagnosis of intestinal metaplasia within the patchy redness. Ueda Sensei, do you understand my
Yes.
issue?
Yeah, I think I agree. So as I mentioned, like color, red, and morphology, depressed from the surrounding mucosa. That is a characteristic finding of depressed type intestinal metaplasia. But patchy redness associated with active inflammation or something usually develop in a flat mucosa and with hyperemia or something. So I think, yeah, morphology is one of the key feature.
Okay, okay. Gianluca, would you add something on this challenging issue of differentiation redness?
Yes. What I think is that now with high definition endoscopes, even in white light, it's easier to see those morphological alterations that Sensei Uedo said. I think that, as you said, in the right image, is pretty clear that you have like a demarcation area. It's what we look for when we perform a gastroscopy. So when you have that morphological alteration, so like a depression and the limitation, so like a demarcation line, you probably have something that you should analyze. Most of the times, even the localization, as Sensei Uedo said, it's important to understand what it could be. But I think that most of the times, especially in the antrum, those type of alterations are usually intestinal metaplasia, so it's easier to understand. Of course, in Western countries, we are not as good as Japanese in doing that in white light images. But now that we have high definition endoscopes, we are a little bit more expert in doing that. So I think it's easier now, even in white light, to understand those areas.
Thank you so much for your comment. It's very wise comment about demarcation line. So morphology makes sense. Depressed, flat or depressed, and the clear demarcation line in the mucosal structure. So I think it's yes, it's could work in clinical practice for this discrimination of intestinal metaplasia and focal inflammation in patchy redness findings. Okay, thank you. So to summarize endoscopic features of GIM in white light imaging endoscopy, intestinal metaplasia could be presented as the whitish lesions and also as the reddish lesions. Ueda-sensei, do we have any associations with morphology? So whitish areas should be flat or elevated, and reddish areas should be flat or depressed. Am I right?
Yes, I think so.
Okay, so that also could be the clue for the differentiation of local lesions that could be suspected for gastric intestinal metaplasia. Okay, let's go next. Endoscopic features and patterns of GIM in magnifying image enhanced endoscopy. And first of all, I would like to show some novel image enhanced technologies like TXI and LCI. So we can obtain more information from the image with TXI technology. So whitish patches become more evident in the TXI mode. So maybe we can more clear, maybe we can clearly diagnose such sort of image, such sort of lesions. And the features of GIM in LCI also could be very specific. It is the lavender color sign. As you know, it is not just the enhancing the image like in TXI when we definitely see this whitish contrast patch. It is the change of color from whitish to lavender. It is very interesting phenomenon when we use LCI. This is the pictures from the paper of Ono Sensei and colleagues when we investigate the lavender color sign in the areas of intestinal metaplasia, also with magnification, magnifying endoscopic images of the duodenum, also has some lavender color of the marginal epithelium of the villi. So it is very interesting effect of LCI. However, when we use narrowed spectrum technologies like NBI and BLI, we have quite specific changes in areas of intestinal metaplasia, light blue, whitish patches. This is original definition from Ueda-sensei paper in 2006. And blue, whitish, slightly raised areas. This is the European perspective and European definition. So this is when we use NBI or BLI, we can get the uniform color of the intestinal metaplasia, light blue color. If it is whitish raised lesions in NBI, it is light blue. If it is flat or depressed reddish areas, it is also light blue in NBI and BLI. So, and the question is, what is the role of new non-narrowed spectrum light image modalities in the diagnosis of intestinal metaplasia? If we have NBI, why we need LCI and TXI in the diagnosis of intestinal metaplasia? Ueda-sensei, what do you think? If we have NBI, what is the role of TXI or LCI?
Probably the difference between TXI and the NBI is use of TXI basically use white light and then just enhance the whitish color to more whitish and reddish color to more whitish. So, but the LCI and also NBI use short wavelength light, only blue and green light, which reflect at the superficial layer of the mucosa. So I think the most difference, specific difference between non-metaplastic mucosa or metaplastic mucosa is the presence of light blue crest, microvilli on the surface, brush border on the surface of epithelium, and fat deposition of the superficial epithelium. So, which is really contrasted by short wavelength light, which is reflected at the superficial layer of mucosa. But the conventional white light use also not only short wavelength but also long wavelength light. So it just not specifically contrasts the color of the difference of color of intestinal metaplasia. So I think LCI or LCI, BLI or NBI specifically contrast the color of white intestinal metaplasia. That is my understanding.
Okay, thank you so much. Gianluca, what is your perspective? What do you think? What is the best modality for highlighting or GIM in stomach?
I think that it's really important, the white light endoscopy. I think that now that we have blue light imaging or narrowband imaging, of course, it's easier to recognize intestinal metaplasia, but we don't have to forget that what we have to do is to start with white light image, the endoscopy, because the BLI or MBI are characterizations lights. So it's important to do white light endoscopy, and of course, LCI or TXI could enhance the visibility in white light, so they could help the endoscopists to see and to have more contrast, but always like white light and not like narrowband imaging on or BLI. And it's really important to see that areas that you should characterize to see if there is intestinal metaplasia. So my perspective is to perform gastroscopy with white light, and of course LCI and TXI could help you to find those areas that are suspicious for intestinal metaplasia. And only after that, you should push the button and use MBI or BLI to characterize it and see if you're suspicious of intestinal metaplasia is confirmed with virtual chromendoscopy. That's my perspective, and that's my what I do in clinical practice.
Thank you. Thank you so much. And just one question about the using of NBI technology, for example. We have very interesting trend in Japan when we start to our investigation with NBI, not with white light imaging, but in NBI when we screen for esophageal cancer. Because we have some evidence that very solid evidence that NBI is better than white light in detecting of squamous cell carcinoma. But in a multi-center study from Pimenta Nunes and colleagues, and Gianluca, you know this study because you was the participant of this multi-center study, we have additional 11% of diagnostic accuracy in NBI mode in comparison with white light high definition endoscopy. What do you think? According to the results of this multi-center study, do we need to have additional observation with NBI for good diagnosis of GIM, or we need just NBI observation alone without, for example, white light endoscopy for diagnosis of GIM? No, but maybe we should not exclude white light endoscopy because our main purpose is to detect neoplasia. However, as we have such evidence that NBI is better than white light, should we make additional observation with NBI? What do you think? It's increased the time of the procedure and maybe the propofol sedation and maybe increased the complication rate. But is it reasonable to make a second look with NBI? Gianluca, first is a question to you.
Yes, I think that it's important to use narrowband imaging or BLI, so the virtual endoscopy. So usually I take a look with a white light endoscopy to see the entire stomach, and then I take a look even with the narrowband imaging or BLI. I think it's important because sometimes only with white light, and as as you know, Western countries are not the Eastern countries, so we are not as good with white light as the Japanese or the Eastern countries. So our use of white light, it's a little bit less expert than our Eastern colleagues. So after that, I usually take a look with narrowband imaging or BLI to see that I didn't miss any area suspected for intestinal metaplasia. So I perform endoscopy with white light, and then before going throw out the scope, I usually take a look with MBI or BLI to see the entire mucosa.
Okay, thank you so much. And that was the question because we have EGIM classification, grading of gastric intestinal metaplasia system when we should use NBI. So according to our practice, first we should observe in white light, and second, we should observe in NBI for checking the areas of intestinal metaplasia if we want to use EGIM. Am I right, Gianluca?
He has disconnected.
Oh, disconnected. Okay.
So
It's
I can answer. Yeah.
Wait a second. Yes.
So yeah, my practice also after observation of the stomach gastric mucosa, whole gastric mucosa with white light for SSS systematic observation. After that, I always switch to NBI to assess the extent, presence, and extent of evaluation for the extent of intestinal metaplasia. So as I mentioned, yeah, shortwave sense light image significantly specifically enhance the color of intestinal metaplasia and facilitate evaluation of the extent of the intestinal metaplasia, which correlate with the risk of gastric cancer.
Thank you. And you evaluate the extension of intestinal metaplasia, and do you use EGIM system scoring system like EGIM?
No, actually, we don't use scoring system, but I think this system, because I use this system for study, so I realized that this is very, easy and useful. We can just evaluate more than 30% or less than 30% each area, like a corpus, lesser curve, and greater curve, something like that. So if it is more than 30%, we can present in a both antrum corpus, we can say very extensive, which is very high risk for gastric cancer, which require surveillance endoscopy. So I think if you're really familiar with this system, we can just distinguish who is really high risk for gastric cancer, I think.
Okay, thank you. And the brilliant idea to have a scoring system, to have some quantity of assessment of the intestinal metaplasia and EGIM score is quite useful for clinical practice. Gianluca, thank you for your reconnection with us because this is the question for you, for European experts, for European doctor. What do you prefer in your clinical practice, and what your doctors prefer, EGIM or OGIM?
That's a good question. Of course, our idea was that it's something difficult for pathologists to stage intestinal metaplasia in the stomach, only taking 5 biopsies or 4 biopsies, because we as endoscopists, we have the idea of the entire stomach. So the stomach, it's a very big organ, especially when we put air inside it. So it's weird that the pathologist only analyzing 5 specimens, 4 specimens, they could stage the entire stomach. So I think that it's better to take a look with the blue light imaging, because as I said, it's something that in Japanese they already did with white light endoscopists, with a light endoscopy. We are not as good as the Japanese, because even with the Kimura Takemoto classification, they were able to stage the stomach, but we are not in European countries. So that's why we used virtual chromendoscopy. So my perspective is that edging could help endoscopists to analyze the stomach and to stage the stomach. Then you can target your biopsies and send them to your pathologist. The problem is that sometimes we have a discrepancy between what we analyze in the stomach. So for me, for example, is an extensive metaplasia, and then for pathologists is not. So that's difficult to analyze. So in my clinical practice, if I have the idea that stomach, I have an extensive intestinal metaplasia, both in antrum and corpus, and then the pathologist says that it's only in the antrum, for example, so it's an Olgim 2, and the patient does not require surveillance, probably I offer to my patient a surveillance, because I am pretty sure that I found some intestinal metaplasia in the corpus. So I believe to my eyes when I see and when I stage the stomach, but of course I take biopsies to have the confirmation from my pathologist. What could change is in surveillance, because we take a lot of biopsies, and probably we don't need, especially in surveillance, to take biopsies again of those patients who require surveillance. And in that patients, I think that edging could be the only option, and it could be a reasonable option for those patients.
Dear colleagues, I have a question for both of you. The question is about the current European and Japanese guidelines. How should we follow up the patients with the intestinal metaplasia according to the current guidelines in Japan or in Europe? I mean that should we need to take biopsy for the surveillance protocol, or just endoscopic data, for example, EGIM classification or other endoscopic data?
So in Japan, actually, I was involved in endoscopic diagnosis of gastric cancer guideline in Japan. But according to the guideline, Japanese guideline, basically, we don't use biopsy for diagnosis of gastritis much. We really rely on endoscopic finding. So if the patient has a high risk endoscopic finding, like a open type Kimura Takemoto atrophy, or we don't distinguish only antral restricted IM or a corpus extensive IM. But if the patient has a IM, endoscopic IM in the gastric mucosa, we recommend surveillance, which is every 2 or 3 years. So Japanese guideline does not describe about the systematic biopsy, or blind biopsy.
In Europe, of course, the situation is completely different. Of course, we have to take biopsies to confirm the diagnosis of our first endoscopy. But I have to say that we are now working on the MAPS-3. And I think that in the new MAPS-3, that I think that they will be published the next year in April, more or less. I think that we will suggest to avoid biopsies during surveillance. So of course we need to perform a quality, an optimal gastroscopy at the diagnosis, and we still need biopsies to confirm our diagnosis. Then when we have surveillance of patients, we could avoid to take biopsies again, and we should refer to those centers who use electronic chromendoscopy to stage the stomach and to confirm the stomach of the patient. That's what we will have with MAPS-3 guidelines.
It is a very important point. Thank you very much for sharing us your experience and your guidelines, because we are going to our national guideline for following up the patients with atrophic gastritis. Thank you.
Thank you so much. So let's go further. Why it looks so bluish? This is the picture from endoscopy, and we often visualize two endoscopic phenomenon, light blue crests and white opaque substance. And if we go further in the magnification force, and the cytoscope could evaluate the areas of intestinal metaplasia and on the cellular zoom. So here we can interestingly use endocytoscope. So the first phenomenon is light blue crests, and this is the paper from Ueda-sensei about 20 years ago in gastrointestinal endoscopy as the abstract on DDW, I guess. And then the first definition, first term was blue fringe, and it was in 2005. And in 2006, we have the classical term of light blue crests, defined as a fine blue-white line on the crests of the epithelial surface or gyri, which is similar in the appearance to light reflected from the mirror. This is an optical phenomenon caused by reflectance of narrow spectrum light on the ciliated surface that can be seen at the tangential observation of the edge of the structure. So this is also a very important point, how to find light blue crests, because this is the area of intestinal metaplasia in the tangential view. We have the light blue crests sign, and if we use cap and our tip of the scope stands opposite the surface, the effect of light blue crests decreased. So, Ueda-sensei, I would like to ask you, as the pioneer of diagnosis of intestinal metaplasia and developer of this term, is it really important to make a tangential view for appropriate diagnosis of intestinal metaplasia? And does the sensitivity of light blue crest sign depend on the endoscopic approach? What do you think?
I think yes, because this is optical phenomena. So the light reflection or maybe appropriate angle of illumination light maybe affect the presence or strength of appearance of light blue crest. So maybe I routinely use cap for observation. So I think we little bit adjust the illumination angle to the mucosal surface and check the presence or absence of light blue crest. So maybe, yes, if someone don't know such kind of maneuver, maybe sensitivity a little bit lower. That
Thank
is my
you.
practical point. Yes.
Thank you so much. Another phenomenon is feature is wide epoch substance that was described by Professor Yao and colleagues, and it was found that it is lipid microdroplets accumulated in the superficial part of gastric epithelial neoplasms. So first, WS was described in epithelial neoplasms in stomach, but not only in stomach, also in duodenal tumors, colorectal epithelial neoplasms, colorectal hyperplastic polyps, and even in Barrett's esophagus neoplasia also. So the intestinal phenotype of the neoplasia could be the background of WOS accumulation. And of course, the white epoch substance marker is the very useful marker for detecting of intestinal metaplasia. We have a quite good accuracy, about 70%. And if we combined WS with LBC, the accuracy will increase up to 90%. But we know that white epoch substance is the dynamic phenomenon. And Yao Sensei and his group also called the novel functional endoscopy technique to use the emulsified lipid food for patients with gastric epithelial neoplasms and intestinal metaplasia. So at this paper, we can clearly it is clearly shown that a neoplastic area without lipid food loading and after lipid food loading. So wide epoch substance accumulates after lipid drops, food loading. And also the prevalence of wide epoch substance is closely associated with the neutralization of intragastric pH. We know that patients often use PPI, and the PPI increase the intragastric pH, and after PPI administration, we can more clearly visualize the wide epoch substance in the areas of intestinal metaplasia. That is my question. Is it important to know about lipid food load and PPI administration when we try to use wide epoch substance as the feature of intestinal metaplasia? Ueda Sensei, is it make sense? Or is it just a phenomenon, or we need to know it in our clinical practice?
So I think theoretically, probably it is better to standardize the condition like a pH or food intake, lipid intake. But there is no systematic data in a real clinical practice. So actually, my answer is I don't know. But theoretically, I think it's better to load or lipid and then increase the pH. At that condition, it's the best to evaluate real extent of intestinal metaplasia. But real clinical practice, we don't do it and then just observe in a various condition, but just observe evaluate the extent of endoscopic intestinal metaplasia.
Gianluca, thank you so much, Ueda Sensei. Gianluca, do you have some personal experience with patients on PPI and patients with fatty dinner the day before procedure and the pseudo progression of intestinal metaplasia because of white opaque substance presence?
As Sensei Uedo said, it's something that theoretically should be asked to the patient, but I don't have experience on that because we usually don't ask to the patient about the dinner before. So if it was a lipid high diet before the endoscopy, so we don't ask. But of course, PPI have a lot of importance on that because we know, for example, even for H. pylori infection, for the diagnosis of H. pylori infection, so we usually try to stop PPIs at least 2 weeks before endoscopy. After that, I don't have experience about the white opaque substance in patients taking PPI against patients that don't take PPI. So I cannot help on that. But of course, it's something that theoretically should be asked and should be probably standardized if we have even more studies about the Western countries about that.
Thank you so much. That is quite interesting to know that white opaque substance could be the dynamic phenomenon and depends on PPI therapy and lipid injection. So, but one of the major point is that first, WS was described in the neoplastic lesions in adenoma and adenocarcinoma. What does it say? Can we discriminate WOS in adenoma and WS in gastric intestinal metaplasia? Could you recommend us some tips?
Distinguish means basically I understand that we just evaluate not only presence or absence of white opaque substance, but we just evaluate the shape of white opaque substance, which reflect the morphology of epithelium. So, for example, maybe I can write. Yeah. So, for example, this is crypt opening in adenoma. And then crypt opening is surrounded by epithelium. And then that is surrounded by interstitium, which include a vessel or some interstitium. So in this epithelium, tubular adenoma, probably the tubular ducts, which has a central crypt opening and the surrounding epithelium is surrounded by interstitium. And then this intestinal metaplasia, usually morphological, epithelial morphology is like a villiform or a papillary shape. So this area, this non-whitish area is epithelium. And then papillary shaped epithelium contain interstitium inside. So I think the shape of white opaque substance represent the morphology of epithelium like this. So left side represent the ductal shape of glands, which is surrounded by network like interstitium. And then this represent the papillary shape, which encase the interstitium inside. So I think the shape of white opaque substance really represent the morphological shape of
Okay,
epithelium.
thank you for your
mucosa.
comments because
Yes.
it's okay. Thank you so much. Thank you for your comments because it's quite important to differentiate adenoma from gastric intestinal metaplasia. Now we understand that brownish crypt in the central part surrounded by whitish white opaque substance is the structure of adenoma, and whitish structure surrounded by brownish lines is more specific for gastric intestinal metaplasia. yes, it's also very, very important issue. But what is the most reliable marker for gastric intestinal metaplasia? LBC, WS, or both? Maybe both. What should we usually use for the diagnosis? What is sensei? What do you use? LBC, both?
I think the both accuracy for each marker, each finding is already published in some article, like a Kanemitsu sensei or collaboration with Kanemitsu sensei, my side. So I think, yeah, I think you can refer to that sensitivity or specificity. So basically, according to Kanemitsu sensei's data, maybe the specificity is both high, but the sensitivity is a little bit lower. So usually if we combine both finding, it increases sensitivity. That is my understanding. And recent study, we found that the white opaque substance is more specific finding for incomplete type intestinal metaplasia. So that is a little bit different specific accuracy. But basically, to make gastric intestinal metaplasia in general, I use both finding.
What does it say? Maybe some novel sign of intestinal metaplasia that we don't know about this?
So far, there is like a marginal bit band or something, but I think still light blue crest and white opaque substance is both very reliable marker in magnifying NBI, I think.
Okay. Thank you so much. Thank you. And just brief discussion on endoscopic patterns of gastric intestinal metaplasia. This is the data from the well-known book, and Ueda Sensei and Yao Sensei were authors of this chapter. And we understand that reached papillary villiform structure is associated with intestinal metaplasia. And we have the same data in ESG proposed simplified NBI classification, where B type is the regular rich tubular villus type with light blue crest sign that is corresponds to intestinal metaplasia. However, sometimes we, in the areas of intestinal metaplasia, proved by histology, we can evaluate not tubular villus pattern, but foveolar pattern. And this is not new, because in the old classification of with magnification chromoendoscopy with methylene blue by Portugal group by Mario Diniz Ribeiro and colleagues, we also have some subgroups with blue round pits and blue small pits. So small round pits also could be the marker of intestinal metaplasia. And according to a fresh paper from Yao Sensei and Ueda Sensei group, we know that foveolar type, so roundish type of pattern, could be also in the areas of intestinal metaplasia. And this is the question that I would like to ask Ueda Sensei, but Ueda Sensei has answered the question, and he Ueda Sensei, I think you answered with the data from this study. Am I right?
Yes.
So the first idea was that foveolar type of foveolar type of the surface should be correspond to complete type,
Yes.
and another type, groove type, is corresponds to incomplete type.
Mm.
However, there were no confirmation in multivariant analysis. Only white opaque substance could be the reliable marker of incomplete intestinal metaplasia with the accuracy of 80%. So thank you for this paper. It is very important. And just several pitfalls and challenges in endoscopic diagnosis of intestinal metaplasia, and of course, the well-known pitfall is the multiple white flat lesions in the gastric corpus that are not an intestinal metaplasia, and this is the letter to the editor of endoscopy journal Endoscopy, the official journal of ESGE, from Ueda Sensei and Ken Shiao and Rina Yamaoka, that novel findings of multiple white flat lesions should not be misdiagnosed as the intestinal metaplasia. And that is the question for you, Ueda Sensei. How to differentiate properly multiple white flat lesions and gastric intestinal metaplasia with white opaque substance? It looks quite similar, but what is the key for differentiation?
That is also bit difficult. But basically, the foveolar hyperplasia develop on the even very normal background surrounding mucosa. For example, like a surrounding mucosa is completely normal stomach, and then it almost like a suddenly elevated. But usually intestinal metaplasia is developed in a little bit flat, although the intestinal metaplasia in the antrum is elevated, but the surrounding mucosa is not like such kind of normal corpus mucosa. But maybe if you see several cases or lesions, I think you can distinguish the intestinal metaplasia from the foveolar hyperplasia. Not a good answer, but that is my comment.
Thank you so much. So it looks different, but sometimes we make wrong diagnosis.
Yeah.
And another pitfalls is the metaplastic changes in autoimmune gastritis. So when we found at the background of diffuse atrophy of gastric corpus such focal lesion, the question is, what is it? Is it the gastric intestinal metaplasia or pseudopyloric metaplasia? And in this case, we diagnosed morphologically pseudopyloric metaplasia, the background of gastric atrophy in patients with autoimmune gastritis. And the paper from Italy also highlighted the problem that current guidelines and current approaches that we use in Helicobacter pylori associated gastritis is not so effectively works in autoimmune gastritis. When we use EGIM, the overdiagnosis of GIM is 78% cases. So EGIM overestimated intestinal metaplasia when pseudopyloric metaplasia without intestinal metaplasia was present, yielding low specificity, 21%. And of course, this is the reason is that PPM and IM may display similar endoscopic features on NBI. Gianluca, can you comment this study? You was one of the participants of this study. It is a really challenge. should we use EGIM in patients with autoimmune gastritis?
That's a good question. Yes, I think that we should use EGIM in patients with autoimmune gastritis, but of course we should consider that sometimes on biopsies you could only find pseudopyloric metaplasia, because we tried in every way to find something different between pseudopyloric metaplasia and intestinal metaplasia, but then we realized that sometimes pseudopyloric metaplasia is similar to intestinal metaplasia, and we didn't find any specific feature of pseudopyloric metaplasia in respect to intestinal metaplasia. That's why our study demonstrated that sometimes pseudopyloric metaplasia could confuse in the diagnosis. But we know that pseudopyloric metaplasia is the first changing in the mucosa. And then after that, probably the patient is going to have intestinal metaplasia after pseudopyloric metaplasia. Pseudopyloric metaplasia probably represents the first steps after atrophic gastritis going to intestinal metaplasia. So I think it's still important to use EGIM even in the diagnosis of pseudopyloric metaplasia, because it's not so common to have atrophic gastritis without intestinal metaplasia. Most of the patients, especially in European countries, they have intestinal metaplasia on atrophic gastritis. So we try to see, and we have some patients that only displays pseudopyloric metaplasia, so atrophy without intestinal metaplasia. And it's still important to recognize it and to perform target biopsies to have the correct diagnosis on those kind of patients. So at the end, finally, my answer is yes, even if we cannot display any difference between pseudopyloric metaplasia and intestinal metaplasia.
Thank you. EGIM also important for diagnosis metaplastic changes, not only gastric intestinal metaplasia, but also the pseudopyloric metaplasia. But the challenge is how to differentiate pseudopyloric metaplasia for velar hyperplasia and gastric intestinal metaplasia. And that's a really challenge. I have no data. I haven't found any information and data about how to diagnose pseudopyloric metaplasia. So that is the area of pseudopyloric metaplasia in the background of gastric autoimmune gastritis, of the gastric atrophy, but there were no systematic approach for diagnosis of such sort of focal areas. Ueda-sensei,
Yes.
what do you think? What is the key features of pseudopyloric metaplasia in patients with autoimmune gastritis?
So I think I cannot directly answer to the question, but I understanding that intestinal metaplasia usually involves surface epithelium as well. So the surface structure also become very beautiful and then express microvilli or something. But basically, pseudopyloric metaplasia is like a granular metaplasia. So not always represent the surface epithelial change. So I think it is very difficult to make diagnosis of pseudopyloric metaplasia by endoscopy from the surface appearance. That is my speculation. And also, the most of the studies so far, most of the study for risk of gastric cancer associated with the mucosal background change, atrophy or intestinal metaplasia is only most of the data is derived from H. pylori associated gastritis. So still, we don't know how much autoimmune gastritis cause increase the risk of gastric cancer. And our Japanese data, probably most of the gastric cancer develop with a combination of autoimmune plus H. pylori infection, previous H. pylori infection, and the pure autoimmune gastritis patients, still the risk of gastric cancer is quite low. And intestinal metaplasia develop only in a very end stage autoimmune gastritis. So I think still it's really totally different etiology, pathogenesis. So still we need to accumulate many data to assess the importance or the risk of intestinal metaplasia in autoimmune gastritis. So what is a real pathological pathway to develop carcinogenesis in autoimmune patients? Still we have to accumulate more data. Otherwise, I don't know whether data in H. pylori associated gastritis is directly converted, applicable to autoimmune gastritis patients. Still, we don't know. That is my comment.
Thank you so much. Gianluca, what is your suggestions and ideas how to improve the diagnosis of PPM? Just briefly.
Yeah, I agree with Sensei Uedo about autoimmune gastritis and the risk of gastric cancer. We don't have still a definition of autoimmune gastritis because we consider autoimmune gastritis patients that has only intestinal metaplasia in the corpus or in the fundus. As I said, the recognition of pseudopyloric metaplasia only in the fundus, it's not easy because we recognize intestinal metaplasia and we don't recognize pseudopyloric metaplasia. The thing is that you should try to do it, and I think we are working on it. That probably, I hope so, that maybe artificial intelligence could recognize some pattern about pseudopyloric metaplasia. So we are collecting a lot of images on that, on patients only displaying pseudopyloric metaplasia instead of intestinal metaplasia, and trying to see if artificial intelligence could help us in recognizing pseudopyloric metaplasia, because it's not easy for us optically to have that kind of image. So I'm not able to recognize it, and I don't know if we will reach that point with artificial intelligence.
Thank you. Very nice answer. So maybe artificial intelligence could provide our best tool for the differentiation. Thank you so much. And so at the end of our session, we have a challenging case from Natalia Semenova, the doctor from Loginov Moscow Clinical Scientific Center. And the challenging case of the diagnosis of intestinal metaplasia in stomach. Natalia, please, we will stop the demonstration and you can share the screen with your case.
Okay, thank you, Roman. Hello, dear colleagues, dear experts. Firstly, I'd like to thankful for that opportunity to take part at that conference, and thank you for so interesting and fruitful discussion about intestinal metaplasia. So I have a clinical case demonstration from our hospital. The patient is a 34-year-old male patient with gastroesophageal reflux disease and detected Barrett esophagus, erosive gastritis, and complete intestinal metaplasia in the previous endoscopy. He regularly takes PPI. He has a family history of esophageal cancer and no family history of gastric cancer. His Helicobacter pylori status is negative. It was diagnosed by C13 urine breath test and antibody serology test. So the patient was referred to our hospital for detailed examination of Barrett esophagus and in the stomach. During the endoscopy, we visualized the long segment of Barrett esophagus without visible lesion. In the stomach, we didn't find any sign of atrophic changes in the gastric body and in the antrum. Also, we can see the foveolar hyperplasia of the gastric body mucosa because patient takes PPI for a long time. At the same time, in the antrum, we can visualize in white light endoscopy multiple flat red lesions. And using the LCI mode, we can see that lesions has pink color, as Roman told before, so-called lavender color sign, which is corresponded to intestinal metaplasia. Using BLI narrow spectrum mode, we see blue whitish tubular Willis pattern of that lesions. and that lesions located in the mucosa with normal structure without any atrophic changes. So I performed target biopsy from that lesions, and the histology showed presence of incomplete intestinal metaplasia, which is located on the epithelialized erosion. So, I have the question to our experts about this case. Should we take biopsy from such kind of lesions, which is has sign of intestinal metaplasia, but on the background of the normal mucosa in patients without Helicobacter pylori infection? And if we perform biopsy and confirmed intestinal metaplasia, should we follow up this patient according to MAPS guidelines, like a patient with precancerous lesions in the stomach? So, because according to these guidelines, patient with intestinal metaplasia, incomplete intestinal metaplasia in antrum, should get surveillance endoscopy every 3 years. So, dear expert, may you please comment and answer to these questions?
Ueda Sensei.
So, yeah. Actually, very difficult case. So, biopsy means if we really want to know the etiology of this lesion, I think it's better to take biopsy so that we can know whether it is intestinal metaplasia or not. But the meaning of, Olga or origin guideline, Olga or origin system is different. Just to assess the risk of gastric cancer by biopsy. So we cannot really refer the such kind of really specific target biopsy result into risk stratification system, I think I understand. So the patient is no corpus atrophy, Kimura Takemoto classification atrophy, and very clear stomach, no H. infection sign, and a very focal, limited intestinal metaplasia in the antrum. So I think the risk of gastric cancer is quite low. So according to such kind of accumulated clinical information, I don't think he or she required surveillance endoscopy. That is my point of view from the clinician.
Thank you so much.
Thank you. Gianluca?
Yes, I have to say that I don't take biopsy from each lesion when I found it in the antrum, because I studied with narrowband imaging or blue light imaging, and I see that it's all intestinal metaplasia. Of course, if you have any doubts, it's always better to take a biopsy, because you could not be able to diagnose intestinal metaplasia, and probably you would think that that's a lesion. So if you have any doubt about that, it's always better to take a biopsy. But what I do in my real practice, I don't take biopsy from each lesions. Regarding the follow-up, of course, our data are a little bit influenced by, in this case, by the pathologist, that we have some studies that show that in complete intestinal metaplasia, it's a higher risk for the development of gastric cancer. But as Sensei Ueda said, when you have only intestinal metaplasia in the antrum, and probably you could consider it as a focal intestinal metaplasia, it's not an extensive intestinal metaplasia in the antrum, I think that probably every 3 years is too much. In this case, I have to say that it's easier because the patient has a Barrett. So probably you have to survey this patient because of Barrett, and probably you can study again the stomach. So in this case, it's easier because you have to offer surveillance to the patient for another reason. So it's easier to manage this patient.
Natalia, could you show us the endoscopic pictures again?
Yes, sure.
Gianluca, what do you think? What, according to these pictures, what is the EGGIM score?
According to these pictures, I will say that there is intestinal metaplasia in less than 30%. both in the greater curvature and in the lesser curvature. So I would say at the end, probably we are in front of an EGIM 2A, because it's one for the greater curvature, one for the lesser curvature in the antrum. So it's an EGIM that it's a low EGIM, so you don't need surveillance in those kind of patients following our paper. And of course, again, I would not take biopsies because there is no clear demarcation line on those lesions. And when you studied it in electronic chrome endoscopy, you can see that you have no suspicious areas to take biopsies on because they are not suspicious for neoplastic areas.
Yes, thank you very much for your comments. May I ask one more short question about this case? If gastroenterologists who refer the patient for endoscopy ask us to perform multiple biopsy for OGA and OGM scoring, where should we take biopsy? Should we take biopsy particular from that lesion, and then we get OGM 2 stage? But if we took biopsy random, not from that lesion, we will not get pathologists will not see intestinal metaplasia or atrophic, and the OGM and OGM system score will be 0. So where should we take biopsy for that scoring?
That's a very good question. According to the study that the Portuguese groups made with the American group, they demonstrated that the best way to perform biopsies is to take target biopsies, but following the Sidney system. I try to explain better. You take a biopsy from the greater curvature, and if you have some areas of intestinal metaplasia in the greater curvature, you should target on that area. Then you should take another biopsy in the lesser curvature. And if you have intestinal metaplasia in the lesser curvature, you should take biopsy on that area. So if you only have intestinal metaplasia in the greater curvature and not in the lesser curvature, you should not take only biopsies on the greater curvature where you suspect intestinal metaplasia, but you should take biopsies, one biopsy in greater curvature where you suspect intestinal metaplasia and another biopsy following Sidney system in the lesser curvature. So if you don't have in the lesser curvature areas suspected for intestinal metaplasia, there you should take a random biopsy. So you have to target your biopsies, but always following Sidney system. So greater curvature and lesser curvature of the antrum, greater curvature and lesser curvature of the corpus.
And it doesn't depend on the distance from pylorus, because sometimes we see